Thanks for coming to our channel. We bring in the most important medical topics every Sunday at 6:30 a.m. Central and 6 p.m. Indian Standard Time. Those are our live seminars. In case if you cannot attend, these seminars are recorded and stored in WhatsApp channel and YouTube channel. This week, we are going to talk about how to diagnose and treat human metapneumovirus infection. What prompted us to choose this topic? Because there is a lots of information in Indian news channel about this virus being spread from China, and the question is how to diagnose, what are the clinical manifestation, does it affect one group of patients versus other, and how to treat. So we are going to talk about introduction, virology, epidemiology of this human metapneumovirus, pathogenesis, clinical manifestation both in adults and children, how to diagnose and how to treat, and most importantly, how to prevent the disease from spreading from one person to another. The human metapneumovirus was isolated from nasopharyngeal secretions collected over 20-year period, 28 Dutch children with URI symptoms in Netherlands in 2001. So it was isolated about 25 years ago. Genetic analysis done on that viral genome shows it has a similar characteristics like respiratory syncytial virus, otherwise called RSV. Serologic analysis indicate the infection with human metapneumovirus is nearly universal by the age 5 years. It can cause substantial morbidity and cost. The human metapneumovirus is a non-segmented, single-stranded, negative sense RNA virus belonging to the order Mononegovirales, family Pneumoviridae, and genus Metapneumovirus. This is an electron micrograph of human metapneumovirus. As you can see, there are spikes on the surface of the virus that shows that protein structure on the surface of the virus. There are multiple proteins have been identified, namely N, P, M, F, M21, M22, SH, G, and L. The most important proteins are F protein and G protein on the surface. The F protein, otherwise called fusion protein, mediates binding to integrins, internalization, and fusion of the virus and cell membranes. F protein is the major target for neutralizing antibiotics as well as the murine and human T lymphocyte immune response. You might have heard the similar protein have been used as a target for immunization in adults for RSV infection. G protein, very similar to RSV, it's a heavily glycosylated protein that may serve as an attachment protein for interaction with host cells. But in human metapneumovirus, it does not appear to be a protective antigen. In contrast, in RSV, the monoclonal antibody against G protein being used to prevent infection in children. Human metapneumovirus infects upper and lower respiratory tract. The peak viral titers seen between days 3 and 5. Lung infection is characterized by alveolar and interstitial inflammation. Although human metapneumovirus and RSV are closely related viruses, the host immune responses to these two viruses are different. Similar to RSV, immunity to human metapneumovirus is incomplete and reinfection occurs throughout life, in part due to poor development of T and B cell immunity. Because of the winter seasonality of HMV, The co-infection with other viral and bacterial respiratory pathogens ranges from 5 to 60%. Similar to influenza, the human metapneumovirus infection has been associated with bacterial pathogens such as strep pneumo. But the mechanism is very different from RSV to influenza. Influenza neuraminidase on the surface promote the adherence of bacteria to the respiratory epithelium. In human metapneumovirus, the viral application is required to increase the superinfection by the bacterial pathogens in the respiratory tract. In addition, it also impairs recruitment to the airways, leading to delayed bacterial clearance. As we know, this is a ubiquitous pathogen that affects all age groups. But the severe manifestations are seen in extremes of age group, both in children and older adults. Seroprevalence studies indicate by age 5 years, most children have been infected with human metapneumovirus. Human metapneumovirus and RS infection occurs in childhood, but human metapneumovirus occurs relatively in older children. The annual hospitalization rate based on United States, 3 per thousand children in children less than 6 months of age, 2 per thousand children age ranges between 6 to 11 months of age, 1 per thousand children younger than 5 years of age. The total 20,000 to 27,000 yearly hospitalization occurs as a result of human metapneumovirus in children less than 18 years of age. As a cause of lower respiratory tract infection in children, human metapneumovirus ranks secondary to respiratory syncytial virus. As you can see, the hospitalization rate in different age groups, less than 6 months is about 200 per 100,000 person years, and 6 to 11 months, there is a higher incidence of hospitalization rate, which is a little bit different from RSV. In RSV, 2 to 6 months, there is higher incidence of hospitalization rate, even though RSV can infect from 2 months to 2 years. This data came from Guangzhou Women and Children's Hospital. They published in 2024 the incidence of respiratory syncytial virus and human metapneumoviruses. As you can see, respiratory syncytial viruses cause seasonal increased incidence in different years, and they are the predominant pathogens. Human metapneumovirus is distant second, but their incidence is higher in 2022 and 2023 when compared to the previous years. This is further breakdown into the different quarters from 2012 to 2023. As you can see, vast majority of that time, respiratory syncytial virus being the most common cause of lower respiratory tract infections than human metapneumovirus. But in some quarters, human metapneumovirus predominates than the respiratory syncytial virus. Other important observation from the same study shows the co-infection rate is higher among respiratory syncytial virus when compared to human metapneumovirus. When there is an underlying medical conditions, more severe the manifestations with respiratory syncytial virus and also with human metapneumovirus both behave in similar fashions when the host has underlying medical condition. When there is an underlying congenital heart disease, and RSV causes severe infection when compared to human metapneumovirus. On the other hand, when there is a protein energy malnutrition and CNS diseases, and human metapneumovirus causes severe infection. Clinical manifestations of human metapneumovirus similar to respiratory syncytial virus, ranging from mild URI to bronchiolitis to severe pneumonia requiring mechanical ventilation. The typical infection causes initial URI-like symptoms after 2-3 days, and shortness of breath, hypoxemia, and poor feeding ensues. The spectrum of the disease depends on the age. The extremes of age are more susceptible to have severe infection. And the health of the host. In immunocompromised host, it runs severe disease. As like any other viral infection, most infections are asymptomatic. Incubation period estimated about 5 to 6 days. Most children exhibit fever, cough, sore throat, and rhinorrhea. Fever appears to be more common with human metapneumovirus than RSV, and also the amplitude of fever is a little bit more higher in human metapneumovirus than RSV. Febrile seizures are more common with human metapneumovirus, 16% versus 3.1% with RSV. Wheezing is common, 22 to 83%. In children less than 3 years, acute otitis media has been documented up to 60% of children. The less common symptoms are maculopapular, truncal rash, and diarrhea. It rarely affects the neurologic system, but it can present as seizures, ataxia, and encephalitis. So CNS manifestations 10 times more common with human metapneumovirus than RSV. This table shows comparison of signs and symptoms in children with human metapneumovirus, respiratory syncytial virus, and influenza A. These symptoms are common among all the three, like fever, cough, rhinorrhea, retraction, wheezing, diarrhea, and vomiting. But there are subtle differences. Influenza often present as acute illness with high fever from the first day onwards. By 3 to 5 days, the symptoms subside and disappears by 7th day. On the other hand, both RSV and human metapneumovirus present as URI symptoms for 2 to 3 days. Then they develop wheezing, shortness of breath, hypoxemia, and poor feeding. Among these two, human metapneumovirus have high fever and little bit more retractions and wheezing than the RSV. Even in children, the symptomatology changes or the manifestation changes with human metapneumovirus infection. In infancy, it causes predominantly bronchiolitis, pneumonia, croup, exacerbation of asthma, URA infection, and acute otitis media. In older children and adults, it's predominantly cause URA symptoms and URI manifestation like croup, laryngitis, bronchitis, and sometimes asthma exacerbation, pneumonia, and exacerbation of chronic obstructive pulmonary disease. Lab findings are relatively nonspecific, lymphopenia, and elevated hepatic transaminases. Chest X-ray has been found to be abnormal 26 to 87% of hospitalized children. The radiographic findings are as follows. Perihalar infiltrates are seen in 87% of the patients, hyperinflation seen in 69% of the patients, and you can see patchy opacities and atelectasis, and lobar consolidations occurs less frequently seen in 18% of the patients. But when you see lobar consolidations in patients with human metapneumovirus, one should suspect and evaluate for secondary bacterial infection. This is a typical X-ray picture of human metapneumovirus infected lung. But obviously, the child has a severe human metapneumovirus infection. The child had been intubated, has a perihilar infiltrate, and expanded both lungs. So most of the time, the children are hospitalized with the following diagnosis. Bronchiolitis, that is the most common clinical presentation when the children are infected with human metapneumovirus. Asthma is second most, and third being pneumonia. The severe disease happens in patients who had premature birth, who has congenital heart disease, and who has bronchopulmonary dysplasia. The other risk factors: female sex, prematurity, esophageal reflux, underlying heart and lung disease, lack of breastfeeding, vitamin D deficiency, and household crowding. I wanted to emphasize on lack of breastfeeding. Either breastfeeding decrease the incidence of human metapneumovirus when they present, the severity is much less than formula fed children. I want to show this particular study published in 2023 from Guangzhou Women and Children's Hospital. It's a 10-year retrospective. This study talks about sex distribution, symptomatology, and clinical presentation, and the co-infection with other viruses. As you can see, the predominant symptoms are fever. Fever is overwhelmingly very important in patients with human metapneumovirus, followed by tachypnea, shortness of breath, diarrhea, abdominal pain, and debilitation because of poor oral intake and the body temperature. In that particular retrospective study, the most common clinical presentations being pneumonia, followed by bronchopneumonia, bronchiolitis, and URI infection. Regarding the co-infection, you can see co-infections have been seen significantly, and the most common co-infection being human coronavirus, even though it can coexist with respiratory syncytial virus, flu, picornavirus, adenovirus, and vocavirus, so on and so forth. But most commonly, coronavirus. In adults, the presentation is a little bit different. Most of the patients, most of the adults present like mild influenza-like illness, common cold syndromes. Some of the adults remain asymptomatic. Sometimes it can cause mononucleosis-like syndrome. Very rarely, it can cause acute respiratory distress syndrome. Rarely, it can cause encephalitis, presenting as altered mental status, headache, and seizures. It can present as myocarditis and pulmonary edema. So whenever you have a suspicion of pulmonary edema or myocarditis, it's prudent to check cardiac enzymes and echocardiogram. Wheezing and dyspnea are more common, especially those who have COPD, asthma, and community-acquired pneumonia as a result of human metapneumovirus infection. Chest radiograph shows patchy and multilobar infiltrates associated with small pleural effusion seen in 50% of the cases. Those with solid organ transplant, chronic respiratory failure, congestive heart failure, and chronic obstructive pulmonary disease, they tend to have brunt of the disease. They run severe disease and last longer. So these patients needs to be protected from exposing themselves to human metapneumovirus infection. How to arrive the diagnosis? There are 4 methods. 1, viral culture. 2nd, immunofluorescence assay. And 3rd, serology. And the most importantly, PCR technique. The reverse transcriptase PCR has been most widely used in the United States to detect. Number 1, you can get it done faster. You will know the diagnosis within a couple of hours. The specimen used for detecting the virus most of the time from nasal washes and nasopharyngeal swabs. Occasionally, when you have a BAL specimen, bronchoalveolar lavage specimen, that can detect human metapneumovirus. Since the virus is ubiquitous, almost everyone will have titers positive, but in order to make the diagnosis, you got to have fourfold rise in the serologic titers. IFI and viral cultures used for experimental purposes. For clinical purposes, the PCR techniques is used. Finally, how to treat these patients? Mostly supportive. Most important, hydration. Number two, make sure the patient is not hypoxemia. If the patient is hypoxemic, need to give oxygen. Third, if the patient is wheezing, it's routinely we use nebulized beta-adrenergic agents, sometimes corticosteroids. Albuterol has been used in 69% of the patients, but the evidence suggests this practice does not improve the patient outcome. But that's still we do in vast majority of the patients. As we mentioned earlier, the hydration is very important when we are treating um, human metapneumovirus infection. Make sure the child takes by mouth well. If the child or elderly does not take well by mouth, the second option would be placing NG tube and feed. Third option is IV fluids. The next is oxygenation. Make sure the saturation is well above 92. If it is less than that, go ahead and start with the regular nasal cannula oxygen. If the patient is in tachypnea with significant retractions, high flow nasal cannula helps to unload the respiratory work. Most of the time, high flow nasal cannula helps breathing better. If high flow nasal cannula fails, the next step forward is RAM cannula ventilation. If RAM cannula ventilation fails, then invasive mechanical ventilation. Sometimes most of the 99% of the patients will get better by these three interventions: hydration, oxygenation, and respiratory support. Occasional patient will end up in ECMO. When we use ECMO, VV ECMO gives better results in patients with bronchiolitis patients. I have done a seminar on high flow nasal cannula and RAM cannula ventilation both in adults and children. If you are interested in, you can look it up in our YouTube channel. Now, how to prevent the infection. This virus survives in the respiratory secretions 4 to 6 hours outside. So make sure we need to use gloves when you're handling these patients so that you don't transmit the infection to someone else. And also they can transmit infection from person to person. So droplet precautions needs to be implemented, especially in the hospital setting. If the patient is a high risk, like as we discussed, congenital heart disease, cardiac failure, chronic pulmonary disease, bronchopulmonary disease, prematurity, and extreme obesity, and those who received the solid organ transplant or anybody who is on chemotherapy, and they all needs to use the mask to prevent the spread from other person to the susceptible one, because there are no vaccine is currently available to prevent the human metapneumovirus. This concludes human metapneumovirus infection, how to diagnose and treat. If you like this seminar, please share it with others, especially with medical students, practitioners, postgraduate students, residents, and others. Thank you for watching.